Hi folks. What you see above me is my favorite splint for lower anterior teeth. I developed this technique in about 2015. I'm a prosthodontist in Northern California and I did all my own lab work. In this short video, I will explain the clinical and the laboratory techniques necessary to create this splint. I will make a long video with more detail in the future. Now for the disclosure. I have never removed one of these, but I can assure you that it would not be an easy task. Be sure and treat your patients with informed consent, and you might want to consider making a splint like this but not bonding it in place for a friend or employee so you get comfortable with the steps in the procedure. And of course, this video is made only for entertainment purposes, and I am not responsible for any treatment you perform for your patients. Thank you. And now on with the video. What you see above me is the typical situation where I use this splint. These teeth are quite mobile. They can be class 2 to class 3 mobile. However, usually the cuspids will be fairly solid. The patient is uncomfortable with these teeth, and the splint makes them much more comfortable. So in order to develop this technique, you need to stabilize the teeth, and I do that with Ultradent blockout material. It's not bonded in place. I block out the embrasures, and this is so that you can produce a refractory cast later on without breaking the cast. Use a custom tray, which is simple to make, and a lingual impression only with vinyl polysiloxane impression material. Normally, you don't even need an opposing impression. Here you see the teeth blocked out so that the impression material doesn't come through to the facial of the teeth. The blockout material, again, Ultradent blue blockout material, stabilizes the teeth in position, and you want to have the patient close into maximum intercuspation so that the teeth, when they move in occlusion, are held in the proper position so that later on when you put the splint in, you don't have to do a lot of adjusting, oftentimes none at all. So this is the lingual impression tray. Simple resin material, light cured, very quick and easy to make. You don't have to send this to a lab. This is the impression of the teeth. It's in a vinyl polysiloxane impression material. You can see it captures all the way to the cemento enamel junction, but almost nothing in the interproximal area. But this is a good impression for this technique, again, made with a custom tray. I'm going to show the laboratory procedures for making this in the next few slides, but they typically are to remove all the undercuts in the impression, any excess undercuts, to pour the impression in speed vest or the refractory material for the vinyl, for the lithium disilicate that you happen to be using. I generally coat the refractory cast with some kind of a varnish material, and then I heat the refractory cast, which facilitates waxing. This I do just with a hairdryer. The refractory cast with the wax up in place. You generally want to wax this at least 1 millimeter in thickness to give it the strength that it needs. I've only had one of these fracture, and I will describe that in a few minutes how I handled that. But if you keep it at least 1 millimeter in thickness, generally they're strong enough. So this is the splint as it looks pressed. You can see I use just 2 sprues. This can be pressed in Emax press or Lisi press, the GC product. Both of them work well. You can see that I made little extensions over the incisal edge, and this helps in the seating of the material. This is what it looks like seated on the cast, and again you can see the little incisal rest, which helps in positioning it for cementation. This is what it looks like, glazed and polished. You want to glaze this pretty significantly. You want it to be very smooth. I generally did not stain them, but that is possible as well. Again, this is what it looks like in a set of hemostats, and this is what it looks like from the lingual after etching. To try in the porcelain, generally if you can use a rubber dam, this is much better. You want to air abrade the teeth. I used to use a Danville little air abrasion tool. You want all the stain removed from the teeth, and then you want to use a total etch technique. If the teeth were extremely mobile, you need to stabilize them with the blockout material again. You want to etch it, bond it, like cure it. And you always want to bond the splint with a dual cure bonding technique. So here's what the teeth look like prepared for cementation. They've been etched, and then you use your bonding material, and again, a total etch technique. Here's what that incisal edge looks like. You can see this is actually cemented in place, and look how open the embrasures are. A patient can easily clean this. Here you can see the lingual view. Again, easy hygiene. And this is what it looks like, from the facial after the occlusion's been adjusted and the material has been polished. As far as cost, generally what I charged for these was the cost of a single crown. It took me less time clinically to get ready for one of these and to cement it than it did for me to do a single crown. Of course, I had done quite a few of these by that time. I did my own lab work, so there was no lab fee for me, but I would generally figure that once a lab has done a few of these, they should be able to complete one of these for the cost of a single crown as well. Thank you. And if you watched this video to the end, I made this video for you, and I'd appreciate it if you would buy me a cup of coffee. Thank you.